And thank you for that very kind introduction. So yes, we're doing a sort of case-led discussions this morning, but I also wanted to introduce some of the newer drugs we've got for cutaneous lymphoma, because we've had very little for a long time, and suddenly we've got 3 new drugs, so I'll be bringing those into our cases. So my disclosures. And these are the drugs. You'll see you have a stand here from Recordati who've got Lydarga clomethin gel. So I'll spend the first part of the lecture talking about this. I gather most of you are dermatologists, so this will be the important new drug to understand how to use. Brentuximab, a drug which the hematologists have been using for a long time for CD30 positive lymphomas, Hodgkin's, and now we're using for CD30 positive cutaneous lymphomas. And then mogamulizumab, an anti-CCR4 antibody that's very good for Sézary blood involvement. So this is Lydarga, it's a gel. It's been available in the States for a lot longer under the name of Valclor, but it's been launched in Europe and UK and worldwide as Lydarga. It's exactly the same formula, just a different name, and it's the old nitrogen mustard in a gel. Lesson trial showed it to be non-inferior to the ointment that was in circulation, which brought it to license. Has a longer duration of treatment and a better response rate. Main side effect, itchy dermatitis. That's not a great thing when you're treating a skin rash. Similar the way you do with Efudex, you need to tell the patient it will get red, it will get angry, but this is the way it's getting better. So they don't use it once and then decide it's no good. No serious side effects, unlike steroids. We're hearing earlier how dangerous those steroids are for our patients long term. So any patient with skin lymphoma early stage, with a chronic disease, you do need to be very careful about the amounts of steroids you're prescribing. And as we heard, checking their cortisol, which I do frequently in my long-term steroid users. So we move on. Who do we use it for and how do we use it? So this is one of my patients, stage 1A MF, very common in the bathing trunk area. Not really enough to warrant coming to hospital for phototherapy, and can manage at home with clomethin gel. I would always give a steroid first. It's cheap and it's effective, but these patients live a long time, and although steroids are good at reducing some of the symptoms of erythema and itch, actually resolving the patch doesn't really happen, but it does with clomethin gel. And they can use it for a few months, up to a year, and it's very effective. It's another patient that's had a lot of therapies, has actually had bexarotene and interferon when he's had sort of thicker plaques, and has now been left with sort of thin, very scattered patches. Patient I wouldn't be keen for phototherapy on because the risk of second non-melanoma squamous or melanoma skin cancers are very common in these patients. We think also that UV light might play a role in disease progression in CTCL. So this sort of patient can just put the clomethin gel all over the body. It's not absorbed, there's no risk. You just need to remember to prescribe enough tubes, because one Lydarga tube has an expiry of 2 months and is a 60 gram, and it won't cover vast areas. The other way that I use in my patients Lydarga is for patients who are having systemic or therapies for advanced disease and they have some symptomatic patches and plaques. Chemotherapy is brilliant at getting rid of high-grade disease, but not very good at getting rid of low-grade disease. So for this, my patient here was receiving radiotherapy, and then these little areas at the back we could treat with Lydarga. You don't have to be specific to the actual area. If it goes on the normal skin, that's fine. a little bit like how we explain Efudex. So to summarise where we put clomethrin gel, it's a licensed indication for all stages of MF. You apply it locally. There's no absorption, so you don't need to worry, but you do get, in about half the patients, a significant allergic or irritant reaction. Now, in a small number of patients, maybe 1 or 2%, they have a true allergy. If it blisters and it's very red, you need to stop it. You can do a simple patch test to it to make sure that it's actually true allergy, but about 1 or 2%, but around about 10%, or the erythema might be quite significant, and you may need to add in some steroids. I try not to. It doesn't really help the patient's efficacy with the clomethrin gel, but obviously you don't want to do any harm for your patient. So I think I've mentioned everything there, and we do have both the RTC and UK guidelines for using clomethrin gel. So then these are the other 2 new drugs which are now licensed for CTCL. So brentuximab, it's a conjugate of an anti-CD30 antibody and vedotin. Vedotin's a toxin, and it kills off the CTCL cells. It was licensed in 2017 for the treatment of adult patients with CD30 cutaneous T-cell lymphoma after at least 1 prior systemic therapy. This is the trial that brought it to license, the ALCANZA trial. It was tested against physician's choice, so you could choose on the randomized arm that wasn't receiving brentuximab, either methotrexate or bexarotene. It did very well. The end point was a response at 4 months, called the ORR4. It was a continual 4 months, and was 56% in the brentuximab arm versus just 13% using our other treatment choices. So a much better drug for CD30 positive disease. Good progression-free survival, 16.7 months versus just 3.5 months on those on physician's choice. So very exciting. Main problem, there's always a drawback, is the peripheral neuropathy associated with brentuximab, which is well recognized by our hematology colleagues. It causes a sensory peripheral neuropathy. They feel numbness in their hands and feet. It's usually grade 1, grade 2, and it's reversible on stopping. You can dose reduce, and you can also increase the time between treatments to try and improve this. So this is my patient. He was 73. He had follicular-tropic MF with patches and plaques, mainly limited to the head area, which is often what we see in follicular-tropic disease. Why are certain lymphomas have certain areas they're more likely to affect, I don't know. Diffuse large B-cell, we know, is commonly on the leg. Follicular-tropic, commonly on the head. Not sure why. Anyway, this patient had large cell transformation, which is when the normal cerebriform, medium-sized cells of MF take on large anaplastic features, up to 4 times. We know it's a very poor prognostic factor. So he was treated with some radiotherapy to the head and neck, but he relapsed quickly. We switched to gemcitabine. He received 6 cycles, had a good response during the treatment between November and May 2014, but had already relapsed in July 2014, and this is what we see, and we don't have drugs to maintain our patients in durable remissions. So you can see he relapsed, looks even worse than he started, now with confluent weepy plaques and tumours. So he was consented to ALCANZA, he got bexarotene, and didn't do particularly well, and after 5 cycles he got to cross over to the active arm. And you can see with quite remarkable improvement with brentuximab, CR after 16 cycles, had grade 1 peripheral neuropathy, but it wasn't affecting his day-to-day living. And he had a durable response for 3 years, so really life-transforming for this patient. Sadly relapsed again, similarly, confluent plaques and tumours, always limited to the same areas around the head and neck, and had a good near complete response after 5 more cycles of brentuximab. Unfortunately, he became quite weak, and he didn't go on to receive any more cycles, but the large bulk of the tumour had been treated. So you can find our UK guidelines published in the British Journal of Dermatology, and you can see brentuximab is placed second-line treatment for our MF patients. So that brings me to the final drug to mention, and a patient case, is mogamulizumab. This drug was developed to treat INT'L in Japan. It was very effective, and then they realized it was very good for skin lymphoma and CTCL. And in 2018, it was granted a license for treatment of adult patients with relapsed refractory MF or Sézary after at least 1 previous systemic treatment. This is the trial that brought it to license. It's the largest trial we've ever done in MF. 372 patients randomized to receive either mogamulizumab or vorinostat and able to cross over. And again, we had positive results in the progression-free survival, which was the endpoint for this study. It was 7.7 months in the MOGA arm. And this is my patient, my final case, 62-year-old with erythrodermic mycosis fungoides. And look at that, a 7-year history of itchy dermatitis. And this is very common for erythrodermic patients. Unless they get full-blown Sézary, the penny doesn't drop. And the trouble is now, with all the biologics, instead of giving up after cyclosporin, methotrexate, and thinking, I haven't got anything else to offer my patient, these patients are getting biologics, which are very detrimental, particularly dupilumab, secukinumab, for our patients, and we see severe lymphoma progression. So please, before you put your erythrodermic patient on these biologics, think to do a biopsy, think CTCL, and do a blood flow. If you can't do it in your lab, send it away. What we do is we look for clones in the skin, we look for CD30 positivity, we look and see if the clone matches the clone in the blood, and we look for aberrancy of these CD4 cells with loss of 7 and 26. It's highly specific to MF. When they're above 30–40%, we really should be considering a diagnosis of Sézary syndrome and a CT scan to look for lymphadenopathy. So when we made the diagnosis, we gave him some methotrexate. We often do this whilst we're trying to get the patient the correct diagnosis because it's safe in most things. So if you do have a patient where you have an index of suspicion for CTCL, then methotrexate is a good, safe go-to. We stopped a few months after loss of response, and he went on to mogamulizumab, had it for 7 months, had a great response in blood and skin, but the lymph nodes were beginning to increase. Repeated the lymph node biopsy, which showed small aggregates of lymphoid cells. So we decided in a young patient, 62-year-old, with an incurable lymphoma, we'll try to get him to an allogeneic stem cell transplant. And we did this after 3 cycles of gemcitabine, and he is now in 12 months after transplant with very good clearing of erythroderma. So the learning points from today and from this last case is that don't misdiagnose erythrodermic disease, repeat skin biopsies if you're in doubt, T-cell, flow cytometry, LDH. Patients with erythrodermic CTCL can have a long survival but with a poor outcome. Treatment responses are usually partial, and we often need consecutive therapies and multiple systemic therapies to induce remission. In an advanced patient in remission, consider stem cell transplant as our only curative therapy. And low-grade relapse may occur after skin-directed therapy. Here are our guidelines, and mogamulizumab is 3rd line in MF and 2nd line in Sézary syndrome. So thank you very much for listening. I hope you found it helpful, and I'm happy to take questions at the end.